Something that is almost never discussed in Malaysian postnatal care is what a caesarean section actually does to the body structurally and what proper rehabilitation looks like. The standard postnatal advice for C-section mothers is to rest, avoid heavy lifting for 6 weeks, and attend a 6-week checkup. That advice is not wrong. It is profoundly incomplete. A caesarean section is a major abdominal operation involving incisions through 7 distinct tissue layers: skin, subcutaneous fat, superficial fascia, the rectus sheath, the rectus abdominis muscles, the peritoneum, and the uterus. The incision surface heals visibly within weeks. The internal anatomy does not simply return to its original state once that surface is closed. Scar tissue forms as the layers heal, and it does not reliably distinguish between the layers it is supposed to bind together and adjacent structures. Internal adhesions, where the scar tissue adheres to the bladder, the anterior abdominal fascia, or the intestinal peritoneum, are found in up to 80% of C-section scars on post-operative examination. These adhesions restrict the mechanical mobility of the entire anterior abdominal wall, alter the resting tension through the lower abdomen, and reduce the functional contribution of the deep core stabilizers to spinal and pelvic control. Fatima was 32 years old when she came to our clinic in Petaling Jaya, 7 weeks after an emergency C-section following prolonged labor with her first baby. She was exclusively breastfeeding, which meant she spent 3 to 5 hours per day in a forward-rounded feeding posture, adding sustained mechanical strain on her lumbar spine on top of the post-operative changes. She presented with persistent lower back pain that had begun in the 3rd trimester and not resolved after delivery, a pulling and tightness sensation at the scar, and an inability to return to any abdominal exercise without discomfort at the incision site. Assessment found 3 distinct problems. First, diastasis recti, measuring 2.5 finger widths at the umbilicus, a separation of the rectus abdominis along the linea alba that is present in virtually all term pregnancies and should progressively reduce post-birth, but had not. Second, a restricted and sensitive scar with adhesion patterns palpable on examination, reducing the mobility of the anterior abdominal wall in all directions. Third, a pelvic floor with significantly reduced tone and coordination, despite the fact that delivery had been by caesarean section rather than vaginally. This third finding surprises many people, but the pelvic floor carries the mechanical load of the growing uterus for 9 months, regardless of how delivery ultimately occurs. The lower back pain had a clear mechanical explanation. With the abdominal wall providing almost no functional contribution to spinal stabilization, the lumbar extensors were compensating throughout every movement throughout the day. Treatment had 3 concurrent components. Scar tissue mobilization began at week 8 post-surgery, the earliest point at which the scar surface is stable enough to tolerate direct tissue work without risk of disrupting the healing layers. The technique applies sustained pressure in perpendicular, circular, and longitudinal directions, progressively restoring tissue mobility, reducing the pulling sensation, and normalizing the sensory response of the area around the incision, which is often partially numb post-operatively. Many women describe scar mobilization as the most unexpected and most impactful element of their postnatal rehabilitation. The change in how the scar and the lower abdomen feel and move can be dramatic within 3 to 5 sessions. The diastasis recti program began with deep transverse abdominis activation in unloaded positions, then progressively introduced functional loading in the postures required for daily baby care. Lifting, carrying, floor transitions, and the feeding positions she was using for hours each day. The principle is not to avoid loading the abdomen, it is to ensure the deep system activates before the load rather than having the superficial muscles drive the movement entirely. Pelvic floor rehabilitation addressed the fatigue and coordination deficit, working toward full contraction force and the equally important relaxation function that is rarely mentioned in standard postnatal advice. At 12 weeks of treatment, Fatima's scar was fully mobile and non-sensitive. Diastasis had reduced to 1 finger width with correct functional loading, and the lower back pain had resolved completely. Her full story, the specific assessment findings at each stage of the program, and the detailed rehabilitation approach used are in the link in the description.